Great. Well, welcome everyone. My name is Joy Burkhart. I am the Executive Director of the Policy Center for Maternal Mental Health. It's great to see, of course, all of our fellows. Welcome to graduation. And to our guests, welcome to all of you as well. We'll give our guests an opportunity to introduce themselves here in just a moment in chat or live. And just a reminder for our own fellows, if you could change your name in Zoom to ensure that we can see your first name and also the state and agency that you represent so that our guests know which organization you're with. That would be wonderful. And it's so great to be together. So next slide, we'll go over, here I am again, Executive Director of the Policy Center. So glad to be with you all today. And just a reminder that our mission is to close gaps in maternal mental health care. And we know that payment reform and public policy and the work that our government fellow policy fellows do, all of you here today, is really instrumental in closing those gaps. So it's a pleasure to be with you, and we'll go over our agenda next. So just a quick reminder, we've done a welcome. We'll do a group photo next, and then we'll do guest introductions. Welcome remarks, just brief remarks from our board chair. And then we have 60 minutes for your presentations, which I know you're all very much looking forward to. We'll go in alpha order, and you have 5 minutes or less. We do have a group Q&A time at the end, but we may ask some questions after each of you present. And then we have remarks from Sage Therapeutics. Grateful to our sponsor, and then we'll close with next steps and closing remarks from myself. Well, thank you, Stacy. We'll move on to the next slide. And we are going to ask, all of you remember, we will do a group photo to celebrate graduation, and we're going to ask that you all turn on your cameras, and we are going to take a photo of you holding your certificate if you've got that handy. If you don't, no worries. But if at least several of you do, that will be exciting. So cameras on, and then I'll turn it over to the team to take the photo. So over to you guys, team. Rebecca.
Okay, yep, I'm here. Awesome. Okay. All right, I'm going to give you guys, I'm going to give you one more second for people to keep coming on. And then I'm going to give you a countdown and I will take the screenshot. Okay. Everybody's smiling. And 3, 2, 1. Okay, I'm going to do one more.
If folks have their certificates and want to hold them up, let's do one of those as well.
Okay, in 3, 2, 1, cheese. Okay, I think that's good. Thank you all.
All right. Excellent. Well, we'll go ahead and screen share again. It's always fun to do the group photo. And then I'd like to turn it over to our board chair, Carla Eckert, who's joining us just to congratulate you. Carla, so glad to have you on, and we'll turn it over to you.
Hi, everyone. Thank you so much for including me today. I'm Carla Eckert Taracena. I'm the chair of the board at the Policy Center. I am also the senior VP for clinical operations at Vasana Health, which is a telemedicine clinic. And so I've been doing the work in women's health for most of my career, lots of time in this area, and just thrilled with the work that the Policy Center is able to do across the board, but specifically with your program, really working with you all in this way in a collaborative building kind of way to try to find out better solutions for our pregnant people and birthing people in all of our states. As you know, the report cards and the county reports that came out recently from the Policy Center show that we have a lot of work to do. And in these changing times, we have more obstacles maybe to overcome. So I am thrilled that you have gone through this program, have done this work. I look forward to seeing a few of the presentations that you have about the work that you will be doing in the future or have already participated in. And the board of directors is a group of people who are here as your champions to be of any service that we can be, or to just cheer you on as you go on this journey. We're really excited about the outcomes of this program and of the work that you're all doing, and we pay close attention, and Joy keeps us very well informed. So congratulations to you all again, and please let the board know, or me, of any support that you might need as you continue your great work in this area. Thanks so much.
Thank you, Carla. All right. Next slide, we'd like to invite any guests that are with us today. Some of our fellows have invited leaders from your organizations and other government departments to join us. So next slide, Stacy. I thought we had a slide, but we may not. So we would like to just we can go back to the last slide, Stacy. It's fine. One more back. One more back. We'll just keep the agenda up. So if you wouldn't mind introducing yourselves in chat, and you're also welcome to turn off your camera and say hello, any guests that are with us today. And I'm taking a peek through who's on camera to see if there are any folks that I see. I only see our fellows. Any guests that are with us today? Okay, we might have folks join midway, which would be lovely. And if you fellows, hello, Amy. Great. Perfect. Welcome from Kansas, Amy. Glad you're here. And I can see you as well. Amy, would you like to say anything else to introduce yourself? It's fine to just do it through chat, or if you'd like to say hello.
Hi, everybody. Thanks for having us today. And I'm super excited to support Kelsey Govt, who has spent so much time with you all and had lots of great things to say about the work being done during this group.
Excellent. Well, we're glad you're with us. And anyone else that's with us? And fellows, remember, it's not too late to invite folks to join now. Amy, we welcome your questions of any of our fellows as well. We've had great engagement from our guests in the past, so don't be shy about asking questions. All right, well, with that, we're going to jump right into the presentations. Again, we're going in alpha order. And so up first, Arizona, you're used to this, our Arizona fellows. We're going to ask that each of you, before you jump into your presentation, introduce yourselves. Rachel, I see you. So we'll turn it over to you. Please introduce yourselves, fellows, so everyone knows your roles and departments, and then jump into your presentation.
Sure. So I will start by saying that my partner, Kate, is texting me saying she is trying to join. And maybe now that I said her name, she'll show up. But I'll start. And she has the first slide, but I can go ahead and introduce myself. My name is Rachel Sally. I work for the Arizona State Medicaid Agency, which has the long name of Arizona Healthcare Cost Containment System, also known as ACCESS. And when I started this fellowship, actually, I was the maternal child health and EPSDT manager, so all things women's and children's health. A few months ago, I was promoted into another position as a deputy assistant director for clinical program management. So high level, I'll still be overseeing that team, definitely not, moving away from maternal health, but I'm going to have some more people underneath me helping it. So that'll be great, as well as seeing some other clinical areas. So if Kate is here, oh, it looks like she is. So I think I can turn it over to her to introduce herself now.
Thanks. Apologies for joining late. My connectivity is not great. I'm in Washington, D.C. today for SAMHSA meetings. My name is Kate Dobler. I am Arizona State Opioid Treatment Authority, and I also serve as the Women's Services Network Coordinator in Arizona. And within those two hats, I am also serve as a subject matter expert within the setting of pregnant and postpartum women with substance use disorder. And so have worked closely with Rachel because of that close intersection between maternal child health and substance use disorder. So it looks like my slide is first. So as a result of the involvement in the fellowship and then really learning about the themes that we discussed each month and then working those theoretical themes into the work of the State Opioid Treatment Authority, HAT, and the Women's Services Network role, I've really integrated that in through a couple of county level cross-sector presentations and events in May of this year, focusing on that intersection of the mother-infant dyad and medical model of substance use disorder, really focusing on understanding that the mechanisms at play within addiction are not moral failings, and they're not about moms making bad choices and bad decisions, and not about moms being unsafe. It's a significant conversation, lots of stigma and bias and ongoing sort of feelings around those concepts, but that's a large part of the conversation that I do and that I support and create space for. Also working to infuse those theoretical themes into substance use disorder treatment system partners and programs really across our state. Working to support family-focused treatment into residential treatment programs, and then that support pregnant and postpartum women, and then being sure that those wraparound supports continue after treatment, and really honing in on supporting the very pivotal treatment provider space of neonatal opioid withdrawal syndrome support and neonatal abstinence syndrome treatment, and the very niche position that the two partners that do that work in our state have, and really working to identify a payment mechanism that will help support that work, because we really need them as part of our system. And I think the next slide is Rachel's.
It is mine. So I'm going to share a few other maternal mental health related initiatives, some of which were kind of started before, but we've been able to expand through knowledge and partnership gained through this fellowship. And there's some themes that we've talked about a lot over the past year that also overlap with what we're doing. And one of our big accomplishments is that we're the first state Medicaid agency in the country to identify and track perinatal mental health certified, or PMHC, providers in our network. I know that our chapter of PSI International is very, very active. They've been amazing partners, and they've been working for a long time to just raise the number of PMHCs in the state overall. But we started working together to look for a way that we could identify how many of them are actually in the Access Network, because we cover over half of all births in the state. So it's a pretty significant impact, considering we know how many people are affected by perinatal mental health conditions. So we developed a methodology where we're able to add an indicator in our provider system to these providers that have the PMHC. So this includes the behavioral health, the prescribers, as well as the lay professional certification. And this gives our MCOs the ability to see who they're contracted with that has this PMHC. So that allows them to see their own network adequacy when they're evaluating adding new partners to credential with them, as well as when they're helping connect people who are pregnant or postpartum to these behavioral health services. They can prioritize these PMHC providers whenever possible. We certainly don't have enough that every single person is going to be able to get that specialty, but we're hoping to maybe get there someday. And one of our big accomplishments was from the period of just June to December of last year. We were able to nearly double the amount of PMHC providers just in the Access Network. There were many more added to the state as well. So we're, as of December, at 93. I think we're about due now for a new list, so it's probably a little higher now. But we went from very low numbers, so even getting this high is a huge accomplishment for us. And we were able to do this again through this partnership with PSI, as well as, they've been able to provide some scholarships because that cost barrier is there for some people who want to be certified but can't afford the training and certification, as well as an access program called Targeted Investments. I know I don't have time to explain all of the details of that, but that is a financial incentive for providers meeting certain milestones in the best interest of our members. And we were able last year to add one for both depression and anxiety screening of new parents and caregivers, as well as for behavioral health providers, sending their providers to go get this training and certification. So I think all of that combined has really added to this number, and I think it'll continue to grow over time. And then I have a couple more things on the last slide. I know we had to pare them down. There's some other highlights of recent and upcoming efforts. As of October 1st, 2024, we were able to cover both group prenatal care and doula services. Even though these aren't specific to maternal mental health, I think we've talked in this program about some of the ways that they can impact and be protective of perinatal mental health. So these are still both kind of in the launch phase, building up that network. So we don't have, the data that I love seeing for looking at impact, but long-term, hoping to see some significant improvements there as well. And beginning with calendar year 2024, our MCOs are going to be required to report on the postpartum depression screening and follow-up measure, which I'm really excited about because we don't have that baseline data yet. We know that screening across the board nationwide is not where it needs to be, but we haven't had a sense of exactly what it looks like at Access now. So as of later this year, we'll be able to see that baseline and move toward interventions to try to increase these rates, because there's no way they're going to be adequate. But I'm really looking forward to that. And I think that'll also help us raise our score maybe a little bit on next year's report card, which would also be exciting. And another big thing that we're going to be tackling over the next year is the maternity care bundle. Like I think probably most other Medicaid agencies and commercial agencies, OB care is usually paid in this bundled rate that varies just slightly based on the type of delivery. But as we know, and we talked about, I think it was just our last meeting, this isn't really the recommendation anymore. Once upon a time it was, and the thought was that it was going to drive good care outcomes. But what we've seen is that hasn't really been happening the way I think everyone was hoping it would. So we're going to just kind of do an assessment of where we're maybe out of line with current ACOG recommendations and just what we know as a field, and look at potential improvement strategies. Unbundling, I think, would be the biggest one, especially for mental health screening, especially because our MCOs are now going to be reporting on this, and that's a lot harder to do when it's included in the bundle. All they have is the administrative data, which I don't work for a health plan, but I've got to imagine is a lot more stressful than just pulling like your claims data. So I'd like to think that this would be, a welcome change for them, as well as, giving us this ability to look at our rates and also incentivize screening.
Awesome. Thank you so much, Rachel and Kate, for your hard work. I know there are going to be questions around maternity care unbundling and HEDIS reporting from a Medicaid perspective. So we're going to save all of them because we have a few more presentations that will address those types of priorities as well. So Rachel and Kate, thank you for your hard work in presenting first. We're going to turn it over to our next state, which is Iowa. Let's see. Do I see our Iowa fellows? Marcus, I see you. And can we please spotlight our fellows? We'll turn it over to you first, Marcus, to say hello, and if you guys can introduce yourselves.
Sure. Good afternoon, everyone. I'm Marcus Johnson Miller. I'm the Title V Maternal and Child Health Director for the state. I'm also the Bureau Chief for the Bureau of Family Health, which oversees our maternal and reproductive health, child and adolescent health, and oral health programs at Iowa HHS. And Jenny, do you want to introduce yourself?
Yes. Hi, my name is Jenny Erdman. I am the Bureau Chief for Quality, Innovation, and Medical Policy here in Medicaid. I'm also have a background in behavioral health, and maternal health falls in my bureau. So my slides first, so I'll go ahead and kick it off. So early this year, we have started work on doing that unbundling of those maternal health global payments. And so really taking a look at what the current payment is that we have in Iowa compared to what the CMS rate is, and evaluating what that package would look like to help incentivize our providers to make sure that our members are getting the care that we want them to need, or we know that they need. Really focusing on those prenatal visits, seeing if we can get an increase in those. We've also included a piece where we're going to open up codes to allow billing for those behavioral health screenings and some counseling as needed to help our members get that care as needed. And then we're looking at adding 3 different providers. Would be the doulas, board certified lactation consultants, and dietitians. And again, just really hoping that providing a space for those 3 really important providers so that we can see people getting access to those services as needed, especially when they have those complex needs that come up. And then looking at, like I mentioned before, so like we really have focused on some specific codes that we can use to hopefully help providers get reimbursed where they might not have been before. So that's all from my slide. I'll kick it over to Marcus.
We've also completed our Title V Maternal and Child Health Block Grant 5-year needs assessment, which will be submitted next month. And we found a really strong focus on mental health and postpartum care. So we'll have 3 national performance measures that really focus on this. So the first 2 are really around the postpartum visit. So making sure that women are accessing a postpartum visit after the giving birth. And making sure that that postpartum check includes recommended care components. So working closely with Jenny and her team to identify what those recommendations will be for the postpartum visit. We're also working with our maternal mortality review committee to ensure that education is happening around some of those top causes of death that we're identifying through the MMRC. Making sure that screenings are available. So those behavioral health, substance use disorder screenings are happening during that postpartum period. Making home visits available for those clients that maybe can't make it into a clinic for a postpartum visit. So making sure a home visit's available. Working with our perinatal quality care collaborative to identify gaps in systems of care. And then also providing education around best practices for postpartum visits that's for organizations that serve pregnant women. We also selected the national performance measure that's focused on postpartum mental health screening. So we'll be working with our local contractors to, again, make sure that behavioral health screening is part of any kind of postpartum care that they're providing. We're working to implement or exploring the implementation of a perinatal psychology phone line to support physicians who are not familiar with serving patients with mental health needs. We're advocating for universal depression screening using a consistent tool, an evidence-based consistent tool, accessing barriers to postpartum clinic visits, providing listening visits when available if there are women with low level needs, and then also collaborating with Your Life Iowa, which is a resource here that we have around mental health and substance use disorder. So we've built out some pages that are specific to maternal health on Your Life Iowa that we'll continue to hone as we build this work out. So just excited to see, the work that we've been talking about in this fellowship really tying closely into the action plans that we're developing for our Title V Maternal and Child Health Block Grant.
Great. Thank you, Marcus. And I imagine, oh, sorry, I'm going to turn it back over to you. Finish your slide.
So like Marcus mentioned, we have really tried hard to work together closely with our bureaus and our divisions. And I would say Iowa HHS in general has really worked hard to make sure that maternal health is a focus. So we have been doing a number of things related to that, like a lot of them that Marcus already mentioned. I mean, his team has really helped us with this unbundling effort on the Medicaid side. And we're also working on, because of the nature of Iowa, really looking at how can we make sure that we're getting access to moms wherever they are. And so that's a new project that we're going to be working on together. And then we also have the CCBHCs, are those certified community behavioral health clinics that are starting up July 1st, and behavioral health redesign that's happening in our state. So all in the name of hoping to improve access for everybody. And then just in general, like for our Medicaid division, we have a quality strategy that we use where we have maternal health and a number of the projects that we've been talking about listed as things that we want to continue to do moving forward, and expect that we'll be working closely with Marcus and his division on a lot of that work.
Great. Thank you, Jenny and Marcus, for all your work in Iowa. Just a reminder to folks that Governor Kim Reynolds in Iowa is recognized as the maternal mental health hero, one of the two this year, for her focus on maternity care and the unbundling work that's beginning in Iowa for maternity care payment, which of course maternal mental health is anchored into and a big part of. So just want to thank you both for your leadership and your state for your leadership. I know there's been a lot of excitement that, this is very much bipartisan, as Kim Reynolds is Republican, and many of you are in purple, blue, and red states alike, right? So thank you both for your leadership. I did drop into chat. I think, Marcus, it'll be interesting for us to be able to continue talking ongoing about how the maternal child health bureaus and states can collaborate, and fund, pilots and priorities, and then set up codes to reimburse through Medicaid and hopefully commercial payers too, for the services that we want to see available to all. So I appreciate, Marcus, all that you bring to the table from an MCHB standpoint. And I did drop into chat the National Maternal Child Health performance measures from MCHB or HRSA. So if folks want to take a look at those, thanks so much. And I know there'll probably be some questions for you as well. Up next, we're going to turn it over to Kansas. And Kelsey, I know you're with us. We'll turn it over to you first to say hello and introduce yourself.
Yeah, hi everyone. Kelsey Fout. I serve as the Maternal and Child Behavioral Health Director in Kansas for the Kansas Department of Health and Environment. And I think I am the sole survivor from the Kansas Policy Fellows team. Kind of like starting this journey, we had partners from our Office of the Secretary representing our Division of Healthcare Finance, which is our Medicaid colleagues, and then also someone from the Kansas Department for Aging and Disability Services, which is our behavioral health authority for the state of Kansas. And then just changes are happening. And so I think I am the last standing person. And so I know Amy is on today providing support, and I'm going to help champion the work plan that we put in place so everything can continue even though staffing has changed. So some of the things that we focused on as part of our action plan was we divided it into both mental health and substance use. So related to mental health, we wanted to increase screening prevalence. So we divided this between prenatal and postpartum. In 2021, we actually passed a Medicaid policy recognizing maternal depression screening as a covered Medicaid service. And through public health and Medicaid partnership, we're able to review claims data on an annual basis. And what we continue to see is lots of pediatricians are screening and billing Medicaid for maternal depression screening services, which we are very excited about. But we kind of put some resources and training materials together as a call to action for our prenatal care providers. It is not bundled as part of the global maternity fee for our mental health screening. And so we think it's just an education issue. So that is our big push and priority, is helping make sure that our practitioners are aware that they can bill for services outside of the global payment. Also in January of this year, we adopted an optional HEDIS postpartum screening incentive measure. And so for this kind of like initial startup year, we're doing, or our Medicaid partners are doing some monitoring for and putting a process in place for measuring real-time progress. So we'll continue working with our colleagues to figure out what process they're putting in place, how we can help support that, and what does like really incentivizing this moving forward need to look like in our state. And then, of course, just general some education around available services, support services in the state. And then for substance use, go to the next slide. Yeah. What we have found is we do have an SBIRT policy, a Medicaid policy. So screening, brief intervention, and referral for treatment stands for SBIRT. But unfortunately, as part of the current Medicaid policy, the only validated screening tool for perinatal populations is the CRAFT, and that's only validated through 21 years of age. So we are pushing for some policy enhancements to include a more comprehensive like screening tool like the 5Ps, and get that added to be a covered screening tool under our policy. There's also some limitations. Right now, you can only provide one screening annually, and so we would like to see that restriction lifted. So that was also part of our policy change request. And we will continue working with our KDADS partners to hopefully make that enhancement. And then go to the next slide. We were also successful in getting 2 different proclamations signed by our governor. So May was recognized as Maternal Mental Health Awareness Month, and then June was recognized as Paternal Mental Health Awareness Month. And to our knowledge, this is the first time that either of those awareness months was formally recognized by the governor's office. So we were definitely celebrating and very excited and proud of that accomplishment.
Awesome. Kelsey, I just want to say thank you for your leadership in this space. And Kelsey's developed some great resources in Kansas that I dropped into chat. We've circulated them to several of you already who have had one-on-ones with us and have been interested in these resources, but wanted to share them with all of you. And Kelsey, I also wanted to acknowledge just you in Kansas pointing out that there's only one tool that may be validated or enough research that's been published on use in the perinatal population, and that the 5Ps are also important. We've raised that now with even the Federal Maternal Mental Health Task Force group. That full group isn't meeting because of all that's happening at a federal level, but other folks are engaged. So just want to acknowledge that and share that you've really been leading the way in many ways. I think some of our other fellows who do work in SUD may have some thoughts and comments on some of these things too. We'll hold that for the end of our conversation, but thank you, Kelsey, for your leadership. And up next, really excited to turn it over to our friends in Kentucky as well. And I'm looking for, there's Judy. Judy, we'll turn over to you. Hi, Angie, as well. We'll turn it over to both of you. Good to see you.
Hello, can you hear me?
I can hear you just fine.
Oh, great. I'm Judy Terrio. I am the medical director for Kentucky Medicaid, and I'm also a pediatrician who I was sitting here trying to think of how many years ago we started screening for perinatal depression in our clinics. It was at least 20 years ago. And so we've been doing it for a while. And then Angie.
Hello, I'm Angie Parker. I'm the Director of Quality and Population Health within the Department for Medicaid Services in Kentucky. Happy to be here and learned a lot.
Yeah. Oh, yeah. It was great. Well, when we worked on our action plan, we really interested in screening because it doesn't seem to happen. I mean, you just got to have to start there. And so we really wanted to create a screening policy that we push out to our providers, our MCOs, to have some sort of a uniform screening policy for maternal mental health as well as substance use with designated CPT codes. And we want the MCOs to do the education to the providers because that seems to be a big disconnect. We start things and then the providers for some reason don't know anything about it. So we really need to get them screened on how to use these tools. And we want the MCOs to consider adding monetary incentive to the providers that do the screenings. And now we know because of last week that a lot of you guys, a lot of states have that monetary incentives for the providers to screen. And so that's actually really encouraging. The screening metrics we've also added to our MCO value-based program. So they get graded on how many of the providers do the screenings. And that is a direct, that we have a monetary withhold. So they have to earn back that money. So they get more money based on how many screens the providers do. So it is important to them to train the providers to do those screenings. I think that's very important, and that just happened. We have not, but we want to require our MCOs to create a maternal health quality management program. But our MCOs are the same as y'all's MCOs. I mean, they're national MCOs that are in every state. And we know other states have this. So it's not, I don't think, too much to ask that our MCOs can start this as well. And we've done a lot of kind of infrastructure building within our Department for Medicaid Services. We formed a maternal health work group about a year ago, and it has our Quality and Population Health Division, it has our Policy Division, and it has some data analytics. And so getting people, from the different parts of Medicaid to work together on maternal health, including maternal mental health, is been actually very helpful. We discussed, this plan with that work group, and it seems to be, going well. Hopefully it's going to work in our favor. The other thing that we've done is we work a lot with our Department for Public Health, and that's where maternal and child health lives. And that's also where our Kentucky Perinatal Quality Collaborative is, our maternal mortality review is, and I'm actually on the steering committee for both of those. And so we do a lot with maternal health in public health, and that's honestly been a wonderful collaboration. It's really good to kind of piggyback on what they're doing, especially with the PICQC, because we're an AIM state, so we do these AIM bundles, and the substance use AIM bundle is very important. We've been doing a lot with those hospitals that are participating. We're also lucky, I don't know if you guys know anything about Kentucky, but in the eastern part of Kentucky is is the Appalachian part. And that is where we have a huge problem with substance use, primarily opiates, but other substances too. We have actually, I just looked at these numbers, 49.2% of the babies born in Appalachia, in a certain area of Appalachia, are born exposed to opiates. So that's 1 in 2 babies in that area born exposed to opiates, and with the diagnosis of NAS. So it's a huge problem. That area also has obviously a higher preterm birth rate, higher infant mortality rate. But that's where our AIM or our PICUC and our AIM hospitals are. So we have targeted the hospitals, the birthing hospitals in the Appalachian region, and we're rolling out these bundles there. So hopefully we can make a big difference and see results faster than if we went in a different area of the state. Let's see. I think that's about it. Maybe the next slide. Great. So we also want to increase the provider's resources for consultation. And we do have, or we're starting, we got the HRSA grant to start our physician hotline for maternal care, maternal mental health. But we also last session had it written into legislation. And so even though, we have the HRSA grant and we're getting up and running, and that's what's funding this right now, it's in legislation that we have this. And so if something happens to the funding, then we still have to figure out how to do it because it's the law now in Kentucky. So it's going to be called Kentucky's Lifeline for Moms, although it is the provider line that they call and ask advice on how to help individual patients in their practices. Right now, we've hired people and we are planning to start in the fall, and we'll see how that goes. We also want to work with our PICUC and they do webinars monthly. They do a lot of educational things, so they can bring in people and do education for the providers where they get CME or CEUs, so they get something out of it, and they hopefully will get educational credits for attending these webinars. I think that's it. I forgot one thing. I'm sorry. One thing. I know I'm running out of time. We're also with our data analytics group, we are starting a study that's going to survey moms perinatal and postpartum and looking at different MCOs. So we want a certain amount of moms from each MCO. We have 5 MCOs. But the good thing about that, we'll survey them on their the care they've received, the education, the information they receive from the physicians, screenings, if they receive screenings, things like that. But we're also going to do focus groups with the moms. And the focus groups are really going to, discuss their pregnancy journeys and what else could have been done, what was good, what was bad, what could have been done better. And so that will be starting in the next couple of months too. So I'm excited about that because it's qualitative and not just digging through claims data. So did I miss anything, Angie?
I think you hit all the high points pretty well. Thank you, Dr. Terrio.
Thanks.
All right. Well, thank you both for all of the hard work. I just wanted to acknowledge, as I mentioned in chat, that Kentucky's the first state, the only state right now that mandates creation of and maintenance, as you pointed out, Dr. Terrio, of the consultation program, though many states, including many of yours, have received federal funding through the HRSA program to start those lines. And we also wanted to share that one of our policy priorities is to consider federal funding for these programs that would go to those states that have already stood them up, including Kentucky, and to potentially have those states serve as hubs to states that don't yet have those programs. So more to come on that. And also wanted to just call out that we dropped into chat. I also dropped into chat one of our reports on the role Medicaid agencies can play in improving engagement with obstetric providers, starting in pregnancy, of course, as a primary care provider, informal primary care provider for mothers. And just a reminder, I know you all have heard this quite often, but new onset of these disorders happens as frequently in pregnancy as in the postpartum period. Of course, a lot of young women are entering pregnancy with untreated depression and anxiety. So I know we all realize that starting in pregnancy is really critical. CMS prioritized the postpartum HEDIS measure first, although the prenatal HEDIS measures are now also recommended, as many of you know, and that's just because the research, body of research started in the postpartum period, in part because, and I think relatedly, rather, the AAP, American Academy of Pediatrics, as you've mentioned, Dr. Terrio, has taken a leading role in detection, recognizing the 2-gen impact in particular. So thank you both for your leadership in Kentucky. Cannot wait to see the progress that you all make in Kentucky. All right, we will move on to the next team here. Louisiana is up next. Let's see if I can find our fellows. There we go.
I think Tangela and I are both on.
Oh, Tangela, there you are. I just saw you wave, Tangela. Great. We'll turn it over to both of you. Good to see you.
Good afternoon. Good to see you guys as well. Karen, I'll go ahead and get us started. So we had 3 team members from Louisiana for this cohort. It was myself, Tangela Womack. I'm the Assistant Secretary of the Office on Women's Health and Community Health. Kim Sullivan, who is the Medicaid Executive Director. She couldn't be with us today. She's traveling for NAMD. And then Karen Stubbs, who is our Assistant Secretary of the Office on Behavioral Health, which you'll hear from a little later. So when we were thinking through our activities we wanted to implement, we referred to the maternal health report card that's published on your site, and we identified the gaps in screening, as much of you have already said before. So the first piece of our action plan, we proposed the inclusion of the addition of the prenatal and postnatal depression screening and follow-up HEDIS measures to be added to the MCO contracts to incentivize them to improve the screening and referral practices. And we believe this is really important to identify those needs earlier and make sure the women in our state are receiving the support they need during their perinatal journey. So to begin that work, we started by surveying the MCOs to verify that they are able to even capture the data needed to report on these measures. And we've actually heard back from 4 of 6 that they do have the necessary data to report on this, which is great. So we're still giving the last 2 a chance to survey to make sure they're able to report on this data before we move forward with making it a requirement in the MCO contracts. And also to support screening and to improve case management utilization, we are amending our MCO contracts to require an opt-out case management for all high-risk Medicaid members. And that means that enrollees would automatically be enrolled in case management based on their clinical criteria for enrollees with special health needs, including pregnant women. And they have to decline the participation rather than having to sign up for it. And we think this model would, it'll automatically connect them to the care coordination that they need, especially those high-risk moms, and they won't have to navigate through the complexity of the Medicaid system to be enrolled. So progress we've made on this action item is the contract changes have been drafted. Again, we are going through some administrative changes as well. So they are routing for approvals, but once approved, we'll be able to proceed with the administrative procedures necessary to publish, and that takes a minimum about 90 days. So with those 2, our last action item is geared towards improving our birthing workforce, and Karen will tell you about a concept that we've come up with.
Hi, good afternoon. So one of the items we started investigating as a result of this group and these one-on-ones was the perinatal mental health certification. I see the comment that Joy put in about Arizona. And so we had no awareness of that certification. And as it was highlighted, we thought that it would really just be a really great addition in Louisiana to really focus not just on our behavioral health workforce, but some other areas of workforce that really had no training in mental health, but especially perinatal mental health. So we're looking at both the actual certification program as well as the quote add-on training to peers, doulas, and community health workers. In Medicaid, Louisiana currently covers state recognized peer support specialists and community health workers, and we are about to start covering doulas. So we thought that could even be a really great kind of kickoff for that coverage, is look into that kind of training. So we're trying to identify kind of the right time and place for when that might be able to happen. For the certification program, we're still researching that. And in fact, we have someone in my office, the Office of Behavioral Health, who's going to attempt to become certified so we can have some firsthand experience on what that 14-hour training and that kind of journey entails. And then we're hoping to maybe encourage some large health systems or a large health system in Louisiana potentially to apply for some workforce development grant funding we have to help them kind of fund that wide scale certification within their system and start in that way. So we really are in the early stages of kind of talking about this and researching and planning it, but it really, really caught our attention when it was introduced to us through this group. And so that is our third slide, I believe.
It's so great to see all the work that Louisiana is up to, and know folks have perhaps tuned into a lot of legislative policy that's passed in Louisiana to attempt to address maternal mental health, but really excited to see the work that the three of you are picking up to, I think, implement impacted change, in a deep way. So just really grateful and excited to see how things progress in Louisiana. Thanks, Tangela and Karen. All right, up next is Maine. Let's see, our fellows from Maine. I'll go ahead and turn it over to you, Maggie. I can see you.
Thanks. Yes, I'm Maggie Jansen. I'm the Maternal and Infant Health Coordinator with the Office of Maine Care, and I'm joined by Dr. Amy Belisle, and she can introduce herself.
Hi everyone, Amy Belisle, I'm a pediatrician. I'm the Child Health Officer at the Department of Health and Human Services in Maine.
Okay, next slide. So for our real premise of our action plan was to, at the Department of Health and Human Services, was really to create a shared vision and goals around maternal mental health and to kind of figure out which department here, quote unquote, owned maternal mental health when it came to implementing policy and really pushing maternal mental health forward here in Maine. And so what Dr. Belisle and I embarked on over the last year is doing just that, really reaching out to the multiple departments throughout the state, and initiating conversation after conversation with the departments like behavioral health, with Office of Children and Family Services, the Office of Maine Care, obviously, and many others. And what we first started off with was to come up with this shared vision and goals around perinatal health and maternal mental health. And those three are listed here, really to achieve the best possible maternal health and mental health outcomes in all areas of our state. Many of you already know this, but Maine is the most rural state in the nation. And we in particular are facing a lot of access issues in rural areas right now, as many hospitals are facing closures. So that is a big piece of the puzzle. We also want to increase overall access to high quality maternal health and mental health for pregnant and postpartum women across the state, and ensure all mothers and pregnant women receive the right care in the right place at the right time. Next slide. So one thing we wanted to do was to build and expand on existing work that is being done by partners within the state. Our state, while one of the larger states in terms of land mass, is a small state in terms of population, and many of our partners, we all know each other well and work well together. And so the MH here is Maine Health. That is the largest health system here in Maine. And they have worked with the RMOMS program, which is the Rural Maternity and Obstetrics Management Strategies program funded by HRSA. They launched a perinatal mental health service with Array Telehealth this year. And that has been launched not just through Maine Health itself, but also to all other networks of health systems throughout the state. So it's really a state-based program. And what we're looking at here at DHHS through our funding through the TEMA model, which we were just also awarded in 2025, is to expand that work as it gets off the ground. We're also looking at expanding work around the MAMA program. It's an app that screens for maternal mental health symptoms, provides a referral service for pregnant and postpartum women who may be experiencing maternal mental health symptoms. Our early intervention program here has begun work around that and done a great job beginning in 2023. And RMOMS has picked that up as well and continued it this year. And you'll see down at the bottom, what I just mentioned is that we're one of the 15 TEMA states. Very excited about the possibilities that TEMA brings with it and really looking forward to expanding our maternal mental health work under TEMA. Next slide, and I'll hand it off to Amy.
Thank you, Maggie. So part of what we've been doing is really inventorying at the state level where we could build perinatal mental health into the different action plans and project work that we have going on. And so Maggie and I have been participating in the Fellows program, and we have looked at the different programs at Maine Care, so our Medicaid program, and Maggie runs the Maine Mom program that's improving care for women with opioid use disorder. They also have an opioid health home, behavioral health home, and certified community behavioral health centers that they have piloting. And so in each of those programs, they've built screening for postpartum depression into their screening tools. Maggie and all the team worked on the TEMA application, and now we will be building perinatal mental health into that program. And one of the projects that we've been working on that we're presenting this week is really looking at the SAMHSA national strategy to improve maternal mental health care and trying to figure out how we bring together the work on around perinatal mental health and substance use disorder in the state to really look at that 2-gen and dyad approach to perinatal mental health. So we've been working on this presentation that we're going to present at our Perinatal Quality Collaborative meeting on Friday. And we've been really, like Maggie said, talking to the different groups across the state to figure out how do we build perinatal mental health into the programs. And, you know, this project has just begun. There's a lot of great work that's happening, but we're really anticipating over the next 2 years really being able to build it into the work, because it does take time at the state level, as you all know, you know, to start new things and to, you know, build it into the workflow and the contracts and the measures and the objectives for the programs. But thank you for letting us join this project over the past year. We've learned a lot from all of you, and we appreciate the opportunity to stay connected.
It's great. And one theme that I'm hearing from multiple states is the role of community-based, the CCBHCs. I'm all of a sudden forgetting what it stands for, but community behavioral health clinics, that is a part of a large federal program that was bipartisan and likely to not go away. So just thank you for flagging the work there. I do think that it's nice to point out to all the states that there's an opportunity here to really tuck in perinatal mental health work and coordinate with FQHCs and really expand access in that way. And thank you for reminding us, ladies, that Maine is the most rural state in the nation. I actually did not realize that. We have a new brief coming out on rural maternal mental health that we'll be sure to share. And thank you for your leadership in that space. All right, up next are our friends at Massachusetts. Let's see, and actually, both of you are here today, I believe. Swati, I'll turn it over to you to say hello first.
Hi, everyone. I'm Swati Damodaran. I am the Associate Medical Director for Psychiatry at Mass Health. I'm also a child and perinatal psychiatrist, and I had the pleasure of doing this fellowship with my colleague, Salma Mohammed, who should be here.
Yes, I am right here. Hi, everyone. My name is Salma Mohammed, and I'm the manager of perinatal and maternal health policy here at Mass Health, working on the parent, child, and family policy team. I came to this work with a background as a community-based doula.
So we really took the opportunity with this fellowship to look at a number of different focuses for our maternal mental health work plan. And one of the areas that we focused on this past year was in perinatal depression screening and reimbursement. It was one of the areas that our state had scored the lowest in our report cards. So we really spent the past year really wanting to understand our current policy. Since 2018, we've already been billing and reimbursing for perinatal depression screening outside of the global obstetric fee. So, but utilization still remains low. And so we're looking at ways to really promote use of this code and support providers using it to bill for perinatal depression screening. And some of the ways that we are currently exploring that is by allowing for providers to bill as many times for the screening during pregnancy and postpartum, really taking their clinical judgment into account. And we are also looking at promoting kind of the clinical guidance that has come from ACOG, that at a minimum, every pregnant person should be screened at least 3 times, once at the initial prenatal visit, once later in pregnancy, and once postpartum. And we're also really interested in kind of taking this work and thinking more broadly about all caregivers and caregiver depression screening, including non-birthing caregivers. And in the fall in 2024, our governor signed a pretty sweeping maternal health bill that actually required for all caregivers to be screened for caregiver depression at every well child visit in the infant's first year of life. So we were part of updating our policy around that. And right now we're looking at exploring whether we can allow for pediatricians to actually bill for 2 screens if there are 2 caregivers who accompany the infant. So more to come on whether we're able to kind of move forward with that policy development. In kind of looking at the screening rates, however, one thing that we heard from our providers is that there's probably a lot more screening happening than what is actually being billed for. So we're interested in really trying to figure out other methods for getting this data and also supporting, perhaps through like a quality incentive program, the screening that we believe is being done in the community. And so this summer, at the end of the summer, we'll have our first data on our CMS maternity core set measurement, which includes the postpartum depression screening and follow-up measure. So we're excited to get that data towards the end of the summer. We've also been talking with some of our plans about the HEDIS measures that relate to perinatal depression and postpartum depression screening and follow-up. And we know that at least one of our plans is collecting this data. So we're kind of in discussions with some of our plans about what do they think about this HEDIS measure? Are they able to calculate it? And are they noticing in their EMRs that more screening may be happening than what's actually captured by our reimbursement code? Next slide.
And as part of our goals for the final action plan, we wanted to also focus on behavioral health workforce development. And one core component of this has been exploring how we can leverage our Mass Health Doula Services program. The Mass Health Doula program was launched in late December of 2023. And since then, we've had over 250 doula providers enroll in our network, which is really exciting. But some of the data that's come out of our first year of the program has shown that a lot of the prior authorizations we receive from our doula providers are due to behavioral health concerns. And so we want to do our best to support this new workforce in accessing more education opportunities around how they can support our members who have some of these higher behavioral health needs. And one avenue that we've been exploring is our doula drop-in hour, which is a monthly space that we host for doulas who are either interested in enrolling with the program or are already enrolled, so that they can share their feedback and ask any questions they have related to the program. And we want to revamp the space to invite some of the experts in substance use as well as maternal mental health to share more resources that are in the communities that our doulas are supporting our members in. And very excited to announce that in the next couple of weeks, we have our first session, which will be hosted on pregnancy and infancy loss. And so we are really hopeful about the work that our doulas can do to support our members in this area. We also have been doing a lot more around educating our doulas on the resources that can be accessed through managed care plans. And so we've updated our doula provider training to incorporate direct contacts that doulas can reach out to at the plan level, since majority of our members are there, and they can get one-on-one support connecting members to enhanced care coordination support, such as behavioral health community partners program. And for SUD, we are anticipating actually implementing enhanced rates for perinatal peer recovery coaches and recovery support navigator services beginning 7/1/2025. And the goal here is to really compensate our peer recovery coaches and recovery support navigators who are going to also, in addition to navigating recovery support services, also support our members in navigating maternity resources as well. Next slide.
So at Mass Health, we've been really trying to use our data in a very thoughtful way. And we have a lot of emphasis on kind of looking at utilization across our services. And one of the things that we found is that people across our agency are using different definitions for pregnancy and postpartum. And this is the challenge with the global obstetric fee, making it very difficult to really define or to know when one of our members is pregnant and what their utilization has been like. So we've been having really cross-program discussions about having a really unified definition and methodology for determining who is our pregnant and postpartum population. And we're hopeful that that will then be able to allow us to look at, for example, behavioral health utilization for the perinatal population to really understand what's happening for these members and what's the healthcare utilization like and where there might be gaps that we can really improve policy. We've also been working with our pharmacy team to just increase access to perinatal and postpartum depression treatments. We already cover zuranolone in our pharmacy program, and so we've been exploring coverage of digital therapeutics with their assistance as well, and so we're excited to explore other avenues of treatment that might benefit our members.
And for stakeholder collaboration, we've been participating in our perinatal and neonatal quality improvement networks, maternal mental health bundle, and learning more about implementation that's happening on the ground with our behavioral health providers. And we have been working in collaboration with them to explore opportunities to provide additional provider education as it relates to perinatal and caregiver depression screening and other Mass Health related services and screening. We also have been participating in a statewide perinatal substance use disorder collaboration as a result of participating in the in-depth technical assistance program, where we are working to support policy development related to infants affected by perinatal substance exposure, including plans of safe care, supportive programming, and community-based linkages to treatment providers, resources, and services for affected families, and really hoping to continue leveraging these spaces to explore where Mass Health can improve infrastructure for providers who are supporting members and families who are affected.
Great. Ladies, I'm going to say thank you. We still have a few more teams to get through with them, just a little bit of time left, but truly incredible work. Many of you heard from Massachusetts at the forum as well, so thank you. I'm sure there's going to be a couple questions for you. Minnesota, I see you, Michelle, on my screen, so I'm going to turn it over to you. Hi, Megan. See you as well. And Alyssa, good to see you. Oh, there.
It would help if I unmute, I guess.
Yep. Great. Go ahead and do brief introductions, and Stacy will get you moving along here.
So I am Michelle O'Brien. I am a family physician. I don't officially work at MDH, but I work on several projects that we have ongoing around maternal health. And then I am a medical director at one of the MCOs in Minnesota called UCare. Megan, you want to?
Yeah, my name is Alyssa Green. I am the Mental Health Systems Coordinator at the Minnesota Department of Health in the Children, Youth with Special Health Needs and Disabilities section. I can hand it over to Megan.
Sounds good. So hi, I'm Megan. I'm with our Minnesota Department of Human Services, and I work in Medicaid benefit coverage policy. And I'll turn it over to Rachel. Or maybe back to Michelle.
Okay.
Oh, there you are, Rachel.
Let's see. Rachel, you're
There
muted.
you are.
There we
You're
go.
muted. Oh, we still can't hear you.
I can quickly introduce Rachel. She's at our Department of Health as well and came on as a late teammate, but a great teammate. You've been so awesome in pushing everything forward. So thanks. Go ahead, Michelle.
Okay, well, hopefully you can make up some time here. I've been really impressed by all the work the other states are doing. One of the things that, you know, when we had our one-on-one meeting, we were talking about the fact that we're across so many different organizations. None of us actually work together. So the work that we did really was trying to build bridges across some of the barriers of working across the different organizations. When we came into this fellowship, our main goal was to try to start a statewide perinatal psychiatric consult line. What we found though is since there wasn't any HRSA grants coming out, and then with all the funding that went away with our current environment, both federally and at the state level, we recognized that that maybe wasn't a place to put a lot of our attention. So then we focused more on maybe creating a coalition so that we could continue this work beyond the fellowship and bring on a lot of the different committees and task forces that we already have in Minnesota. We have out of MDH, a Maternal and Child Advisory Task Force. We have a state perinatal quality collaborative, which has several initiatives addressing maternal health and maternal substance use. There's the Innovations for Maternal Health Outcomes in Minnesota, which was a maternal innovations grant from HRSA. That is one of the groups that I participate in at MDH on the perinatal subcommittee. And we are working on also as part of the iMom project, creating a perinatal dashboard, which hopefully we will have some information on there about perinatal mental health. There's also a task force on pregnancy health and substance use disorders, as well as maternal mortality review committee. Next slide. So as I said, we quickly realized that there was more background work that needed to happen before we could start the work on the consult line. We had the resource of an intern working at MDH with Rachel, who helped do a lot of the research, got us a lot of information about maternal health and mental health task forces across different states and federal level, and created a nothing. Sorry about that. One of the things that we did focus a lot on is there is a mental health group, the Prairie Care perinatal maternal mental health program that they have. Their staff, we met with them several times as they were working to push forward legislation about screening and reimbursement. Unfortunately, we just found out session just ended and that did not move forward, but we plan to continue to work with them to see how we can approach it in the next session. Our state report card, like many others, screening and reimbursement is an area where there's lots of work to be done. We do not have an inpatient or residential maternal mental health program. We don't have a task force or commission. And we don't have any measures for health plans to have a quality program management program. So as I said before, we ultimately have pivoted to focus on building coalitions so that we can take on all these tasks and projects across the different organizations. Next
Thanks.
slide.
And if you can wrap up in like
Yep.
30 seconds, that would
Okay,
be.
yep.
I'm so sorry. It happened to you at the end.
No, that's okay. So some things that we're doing this week, there's a Beyond the Baby Blues conference where I'm going to try and network with stakeholders. We're going to continue to work with Prairie Care, support the work of moving forward the legislation. We are a TEMA grant recipient, so we think there's going to be lots of opportunities there as well. And then just finding champions within the legislature to help us pursue the Maternal Mental Health Task Force in the consult line.
Great. And Michelle and team will stay in touch about those things as well. Appreciate you. And let's turn it over now to our friends in Nevada. Yvette and Karen, I think you're both on. There you are, Karen. I can see both of you. We'll turn it over to you.
Hi. I'm Karen Fox Hennessy. I'm a program specialist and policy supervisor with Nevada Medicaid in our medical and dental benefits coverage unit. And both Yvette and I are part of Medicaid, Nevada Medicaid, representing Nevada Medicaid. If you could, first slide, please. Thank you. So Nevada has been focused on our maternal and child health efforts and prioritizing them. We initiated a clinical steering committee that's focusing this year on specific research into national trends, utilization of our services, and the corresponding health outcomes in our communities. And this work will enhance and we'll use it towards our long-term efforts and a core continuum of maternal health services. We are already offering a lot of things, a lot of services that we have been working on for some time, include things like our 12-month postpartum expansion of coverage for pregnant individuals, which includes an automatic eligibility review at the end of that 12-month period after birth. We have birthing centers and certified nurse midwives who are able to bill the global obstetric rate. But we have a piece in there where if they do not deliver, then they will not get that obstetric rate. We have other little pieces of reimbursement there. We enroll both doulas and CHWs. We provide doula visits for pre, ante, and postnatal period, including delivery with up to 9 days of postpartum services. And these also include overrides for those services. So if a PA is written, we can go ahead and approve those services 9 days postpartum. We have CHWs, and they also have a similar situation, services with a provider with a PA override. And we have expanded dental services available to pregnant individuals. We have LARCs in our inpatient maternity stays, our FQHCs, and our rural health clinics. And we recently implemented a breast pump benefit for pumps and supplies that can be delivered directly or prescribed by the hospital or a qualified healthcare professional, as well as delivered through the DME provider. Next slide. Nevada Medicaid covers a broad array of mental health and substance use treatment services. And in addition to a strong momentum that we're putting behind our children's behavioral health transformation project, our action plan kind of looked at assessment and quality measures for maternal mental health. And so that involved, we looked at screening and reimbursement of perinatal depression, excuse me, screening and reimbursement for postpartum depression screening. Both of those things are offered through fee-for-service. Anyone can get screening depression. We don't necessarily have a mechanism for pregnant individuals. In our MCOs, they are delivering both the perinatal and postpartum screenings through office visits, and they're tracking those as HEDIS measures. And there continue to be discussions on best practices or tools. Hold on, I'm going to take a sip of water.
Great.
Our MCOs continue to deliver maternity services as value-added benefits. And one thing we're doing is developing a quality management mechanism. That's a more long-term goal. Next slide. And finally, as our state shifts to statewide managed care, the service delivery for pregnant individuals is a primary focus and includes challenges that come with rural and frontier provider area access issues, which we have. Our work includes focused efforts on addressing mental health needs through pregnancy and postpartum, and the expansion for overall pregnancy services. So just a few things that I'll point out. We're looking at better ways to reimburse providers for the care they deliver. So we are reviewing an increase in our birthing center rates. We're also looking at unbundling services and other carve-outs and accountable care organizations related to maternity services. We are looking at our services related to family planning and primary care models. We are looking at our home visiting program that is provided through our Department of Public and Behavioral Health, one of our sister agencies. They have a maternal, infant, and early childhood home visiting model that they are currently supporting in that agency. And I think that's it. So I'd just like to finish by saying we're really pleased with our improved report card grade for 2025. And we want to thank the Maternal Mental Health Policy Center for including Nevada in this work and allowing us to learn from the successes of our state partners. Thank you.
Great. Thank you both. We are really excited to watch the work that you're up to, particularly in the Medicaid space. Thank you. Oklahoma, Flake, I can see you. We'll turn it over to you. And my apologies, guys, to try to keep it even under 5 minutes so we can get to the last state as well, West Virginia.
Okay. Hi, everyone. My partner is here, but I'll go first. So my name is Flake Adedeji, and I'm the Chief Quality Officer for our Medicaid agency. Tanisha Hooks is here. So Tanisha, I'm going to let you introduce yourself and kick us off.
Sure. I'm Tanisha Hooks. I'm the Director of Behavioral Health here at the Oklahoma Healthcare Authority. And as like I said, I'll go ahead and kick us off. So I think one of the big things that stood out to us was the maternal mental health scorecard, and that has kind of been one of our guiding factors on the things that we want to work on. So I just want to hit our top 3 things that we really want to work on is expanding access to services for expecting mothers, increasing awareness of our 12-month postpartum coverage, and improving screening rates and ensuring appropriate referrals after those screenings are done for mental health and substance use disorder. What we've been doing is having several meetings with a lot of different external stakeholders and sister state agencies. So we plan to collaborate with our Oklahoma State Department of Health and look at leveraging, utilizing their pregnancy resource navigators. We've been working with the Evolutions Foundation, which is a community coalition. So they are out in the community. They have these relationships. So they will help us leverage some of these relationships that we're trying to make with primary care and also with providers in those areas and expecting moms. And we're looking at utilizing other external partners as we leverage the TEMA grant work to push these efforts forward. So overall, our goal is to increase the awareness of and the access to maternal mental health services in primary care practices across Eastern Oklahoma. And so what we also plan to do is utilize leveraging our CCBHCs. We have CCBHCs that serve all 77 counties here in Oklahoma. Many of them actually do have maternal mental health services. So I think that that's going to be something that we end up eventually looking at as we're looking at the screening. Now, where does the appropriate referral go to? So those are some of the things that we're going to be working on. we offer those doula services already through our Medicaid program. And so yeah, I think that is going to be kind of it for me. And then I'm gonna kick it over to Falake because I know she has to get up out of here.
We
To
can
let her
go.
take the second slide.
We can jump on the next slide, and I'll talk more about our managed care partners. So we, Oklahoma recently, about a year ago, just moved to managed care organizations. So we're fairly new in the business, but we do have great partners, and our partners are very invested in improving our maternal health outcomes. And so some of the things that we've kind of talked to them about improving or just working on together. So the way we're structured, we've kept some populations in the fee-for-service, but most of our pregnant women and most of our female of pregnant age, childbearing ages have actually moved over to managed care. We are a very tribal heavy state. And so we gave our tribal members the opportunity to opt into managed care. And we found out that several of them have actually chosen not to. So they remain in the fee-for-service world. So the Medicaid agency will continue to provide care and access to care for the tribal members that did not opt into Sooner Select. That's our managed care entity or our managed care program. So we really do want to work with our managed care partners on reporting postpartum depression screening. We have extended postpartum coverage for 12 months. But one of the things that we've realized is our providers aren't even aware that they have, that our members have 12 months coverage. And so we're currently working with a physician consultant as well as some stakeholders from the behavioral health community to craft education that we're going to take into practices to kind of talk about what we have available, what we want to focus on. And I'm looking at Joy, and I know that I need to round up. But all of this to say we're a team estate, and we do believe that the TIMA grant is going to help us accomplish some of the goals that we have.
Awesome. I really am very excited about the work that's happening in Oklahoma and the other TIMA, CMS TIMA states. Rhode Island and West Virginia, we are asking that those of you who don't have hard stops, please stay on. We are also, of course, recording the call, and we will stay on past 12 Pacific, 3 Eastern for Q&A for those who are able to stay on a full half hour later as well. So Rhode Island, turn it over to you.
Hello, my name is Colette Onedjikwa. I am the Rhode Island Medicaid Pharmacy Director. I will just jump right in. I'll go right to the first slide. Try to get through this really quickly. We have several, so with starting the fellowship, we've looked at all of our programs, work groups, and committees, and we have several that are working collaboratively to address maternal mental health. More recently, we developed the Medicaid Maternal and Child Health Work Group, and the goal is to conduct an agency-wide review of maternal and child health care and coverage, and document our findings and prepare an overview with recommendations for Medicaid leadership. I am the co-chair for the work group for the Maternal and Child Health Work Group. I'm also a member of our Rhode Island Pregnancy and Postpartum Death Review Committee, which I have been since it was established in 2021 when I was previously with our Rhode Island Department of Health. And so that is a multidisciplinary review board convened by the Rhode Island Department of Health. We examine the deaths of individuals who were pregnant or within 1 year of pregnancy to identify contributing factors and recommend public health and clinical interventions. We have the Compass Plus initiative. That is a 5-year grant-funded initiative through Women and Infants Hospital that aims to implement the perinatal collaborative care model in 6 perinatal clinics throughout Rhode Island. And then our Rhode Island Moms PRN, which stands for Rhode Island Maternal Psychiatry Resource Network. That was launched in 2019, and that's a statewide program that's developed through a partnership between the Rhode Island Department of Health, the Center for Women's Behavioral Health, Women and Infants Hospital, and Care Transformative Collaborative of Rhode Island. And so they are funded by a 5-year grant from the U.S. Health Resources and Services Administration. And then in June of 2024, there was legislation allocating up to $850,000 from the state's immunization account to fund the Mom's PRN program to provide maternal mental health services. And so I'll go to the next slide. And so this is the essentially Rhode Island Medicaid. We aim to ensure access to necessary medications through the pharmacy program. And as the new pharmacy Medicaid director since last year, part of that is doing a full landscape analysis of our pharmacy benefits. And so looking at what is currently covered and with regards to postpartum depression, and then also making recommendations for posting clinical criteria for prescriber guidance and improve access. And so the last item is we do have a recent MCO requirement to submit postpartum depression screening and follow-up under age 21, and that will begin in 2026.
Great. Thanks so much. I know, Colette, you had to rush through that. I'll turn it over to Kelly and Keith. Kelly and Keith, over to you.
Thanks, Joy. My counterpart, Keith, wasn't able to attend today, but I am Kelly Mallory. I work for the Bureau for Medical Services. I'm the Grants and Special Project Manager. And so basically one of the things that we're working on is to promote data collection on maternal behavioral health to improve services and outcomes. Data is one of our biggest concerns, and we don't get a whole lot of that. So we've been meeting with the MCOs and claims data system to collect data on maternal behavioral health. And we're also working to promote collaboration between healthcare systems and the West Virginia Health Information Network, because they provide a lot of information. You know, when someone goes to the doctor or hospital, they can just look at their visits and see what's going on with the person and try to treat them as a whole person instead of siloed different issues that they're coming in for. Next slide. Also, I wanted to mention that EDS is our substance use disorder dashboard, and it tracks claims data related to SUD treatment in West Virginia and in each county. So we're developing a subset of this system to review pregnant and postpartum women for up to a year after giving birth, to determine their SUD treatment and which one is most utilized. This includes PRSS, residential, MAT, and any SUD treatment through telehealth. We will also be looking at other co-occurring diagnoses such as depression and anxiety. So SUD treatment programs, the residential and the drug-free mom and babies, we want to provide maternal mental health screenings upon discharge. We want to determine current number of screenings that are occurring now and have utilization managers add a check on screening tool at discharge. And this is to improve early detection and diagnosis of maternal behavioral health condition. So while we've been partnering with outside agencies to see what their needs are. We also partner with the Perinatal Partnership to let them know, hey, how can we partner to figure out how to get everyone screened for maternal mental health conditions. And so the Perinatal Partnership sent out surveys to providers and participants to help identify the needs. We got a lot of responses. It resulted in hospitals develop an AIM task force, providing postpartum morning sign education, of course, referrals to treatment. So that was really awesome. But some of the things that we identified is once they are screened and have a positive screening, the thing is, then what? You know, the providers are like, then what do we do? So we are now developing kind of like a workflow process on what happens after a positive screening, and who can they be referred to?
Great. Did you get to finish? I wanted to make
Yes, thank you. Thank
great.
you.
Awesome. I'm not sure if Stephen, if you're on, but just I wanted to say thank you to you and Sage Therapeutics for all of the investment in this very critical work. As you can see, some really very important work happening in the states through our government agency fellows. Stephen, if you are on and want to say a quick hello, feel free. I did message Stephen to say I would just make remarks on his behalf. If not. Okay. He sends his regards. He's been listening to most of you and will be watching the recording later. Thank you so much, Kelly, for your presentation. We are going to move into Q&A, even though we're over time. Want to give folks a chance to ask questions. Of course, we are going to keep the listserv open, so keep your questions coming, even if you have to drop early, and you know how to find us as well. So let's open it up for roundtable, Q&A, and discussion. You can go ahead and unmute your lines and ask your questions of each other. Guests, feel free to ask questions as well.
Hey, this is Kelly from West Virginia. I don't have a question because I've just started looking over Kansas. So it was Kelsey from Kansas. I may reach out because I just started looking over the information that you have available, and maybe talk about your workflow process and how the referrals how the referrals are going with these people that have positive screenings.
And we may want to do a special session with Kelsey as well if there's additional requests. Kelsey, if you're willing and you're on to do a separate session, I think that makes a lot of sense. Kelly, thank you for the pat on Kelsey's back. I know several of you are excited about her work. Anyone else? I'll just quickly share with regard to HEDIS. One of you, and I can't recall who it was now, had reminded or shared with me that the CMS core set requirements or specifications are different than the National Committee for Quality Assurance specifications around reporting, and CMS gives a little more flexibility about the how screening is measured. So I just wanted to mention that as you all start to think about postpartum depression monitoring, and also pregnancy depression monitoring and follow-up. Any questions, comments on that from folks who are on the line? And I'll just quickly add that the way NCQA currently lists their specifications, they changed them. They used to include claims data and case management data. And we learned actually in March at our forum that the current specs, which several of you have commented, you have to pay a lot of money to access their current specifications. I think it's $10,000. Limit to LOINC codes. So those of you with health information exchanges and maybe very few large MCOs might have luck with LOINC codes, but others may struggle with that. So just wanted to call that out, that as you progress in that space, we'd love to have you keep the conversation going. We'll be also doing a special session, we hope, with NCQA and all of you to talk about screening and the new measure, how the measures may be modified in the future. All right. Anything else? Well, keep us appraised all of your work. We have the listserv open. Stacy will remind all of you, actually, and if you could now email this listserv, and of course I didn't cut and paste it, but Maternal Mental Health Government Agency Fellows 2024-2025 at googlegroups.com. Stacy, maybe you can remind everyone in your follow-up email to email that. We want you to just say thank you. It was great. And then anytime you type in maternal mental health, it will pop up and you'll be able to ask questions of us and your fellow fellows on an ongoing basis. If you haven't done the second bullet, I'm moving out of order here, send your deliverables, including a paragraph summarizing your work. We are requesting that, and also to complete your evaluation. We think there's just one or two of you left to do that. Stacy, one last slide. Oh yeah. We're also going to be asking you next year to give us an update on your progress through a paragraph. So please do be open to sharing your progress with us so that we can share success with others, including our funders. And then if you ever have an ongoing technical assistance request, we are here for you one-on-one, but also are looking to partner with our TMOS states on an ongoing basis, perhaps through contract arrangement at a federal level or state level. And then we will be scheduling larger group TA topic-specific calls. And then a couple of you have asked for quarter or twice a year calls on updates for each of you to give an updates on how things are going so you can continue to learn from each other. So more to come. We're going to be in touch and supporting you on an ongoing basis. And we really appreciate all the incredible work you're doing to support maternal mental health. Congratulations. And on that note, we thank you, and congratulations. We'll be in touch to follow your progress. Thanks all.
Thank you.
Take care, everyone. We'll be in touch.